Tumors can arise in any part of our body. So basically, if it is arising in the orbital cavity or if it's encompassing any of the structures that reside inside the orbital cavity, they would be regarded as the orbital tumors. Now, there is the vast variety of the orbital tumors that we usually come across. There are a lot of presentations that we may go through whenever we are dealing with an outpatient department. It is depending upon the location of the orbital tumors that it would vary along with its signs and symptomatologies. If it's a retroorbital tumor that is located at the apical cone of the orbital cavity, it is going to have the features of compression syndrome in the orbital cavity. That would involve the compression of the optic nerve primarily, as well as it is going to present as a case of proptosis in the outpatient departments. When you'll further investigate or go through the further investigations in this particular case of proptosis, you would find out on radiological examinations that there is a mass located at the apical margin or at the apical border of the orbital cavity. To get to know these patients very well, you should be well versed with the applied anatomy of the orbital cavity as well. That is, the main focus over here lies upon the walls of the orbital cavity, the roof, the floor, the apical cone. We may recall from the basic knowledge regarding the orbital cavity that it's basically a pyramidal shaped or a cone shaped cavity with its base that is situated anteriorly and its apex is situated posteriorly. So if there is a mass that is located at the apical cone, it is going to pressurize the structures, the very important structures that are passing through the superior orbital fissure as well as the inferior orbital fissure, including the optic nerve, including the vascular structures, the muscles. All of these will be compressed due to that mass, and that is basically going to be regarded as the compression syndrome that is produced due to the orbital cavity over here. So over here, first of all, we're going to start off with the primary orbital tumors. As we all know, when we talk about the neoplasms elsewhere in the body, we have the different types towards these neoplasms or these tumors conditions. It can be the primary tumors arising in the locality of the orbital cavity, mainly the structures that are lying over there, for example, the nerves, the mesenchymal tissue. It can be the embryonic or the developmental tumors that can develop along with the infant. And they're basically the inborn errors due to the genetic differentiation. And that is basically going to result into these genetically related tumors. And there are some syndromes that we'll talk about later on. And they will also present as orbital tumors. So if it is the structures that are lying inside the orbital cavity, or it is the bones that are surrounding the orbital cavity or that are basically in making of the orbital cavity, including the frontal bone, we have the maxillary bone, the lacrimal bone. All of these, if they're involved in this tumorous process, then it is called as the primary orbital tumors. Now, there are different sorts of the primary orbital tumors that we must know. One of it is the liposarcomas over here. Then we can have the fibromas that would involve the fibrovasculature of the orbital cavity. And then we have the fibrosarcomas. They are a sort of a malignancy. So it's again very important that there is this differentiation between the benign and the malignant sorts of the tumors when we are classifying a patient to be suffering from orbital tumor, or he or she presents to you in an outpatient department and you diagnose him or her to be a case of orbital tumors. You should know that either it is a primary, a secondary tumor that has invaded from the neighboring cavities, for example, the nasal cavity, or the sphenoidal bone, or either it is a metastatic tumor from distant areas of the body. And again, you would classify this particular kind of a patient, whether he's suffering from a benign kind of a tumor or either it is a sarcoma, for example, it is a malignant kind of a tumor that can spread very vastly and it has its own devastating effects on that individual whom we are treating. Then we have another kind, which is basically the fibromatosis. So the histological features over here are again very important, and that is basically going to lay the foundation whether it is a benign or whether it is a malignant tumor that this patient is suffering from. So the further investigations, obviously, you would perform the baseline investigations in this particular individual, performing the blood CP, the ESRs, and all of the baselines, and then finally, you're going to perform the radiological examinations just to see the extent of the tumorous condition, whether it is involving the other neighboring structures or not. And that will basically highlight the fact that whether it is a malignant or either it is a benign sort of a tumor that we're dealing with. Now, again, this differentiation is very important. This classification is very important whenever we have these patients. We have to classify these patients whether they are suffering from a benign or whether they are suffering from malignancy. The presentation would be quite different in all of these conditions. If there are the primary orbital tumors, for example, the structures that are lying within the orbital cavity, it can be the optic nerve, it can be the sheath of the optic nerve that is involved in the tumorous conditions. The sites and the location, they have to be documented as well, whether they're located apically or whether they are located laterally, they're involving the floor or the base, the medial or the lateral walls, because that is going to affect the final presentation of the individual or the final presentation of the patient whom we are treating. If it is the optic nerve, then the patient is going to suffer from ophthalmoplegia, of course, because that is the major nerve supplying the extraocular muscles for the extraocular movements in all of the 6 cardinal directions. And that is why if that nerve is involved and it is basically being invaded by the tumorous cells, then all of these cardinal motions are going to be affected in the patient. Talking about the primary orbital tumors, we have the different sorts of tumors. For example, we have the dermoids on one hand. So it's again one of a developmental kind of a tumor that we usually come across. It is a common developmental tumor that we usually come across from the embryonic displacement of the epidermis. So what basically is happening over here, if we just remember, or if we just go through the embryological stages of the development, we're talking about the epidermis, and due to the displacement of the epidermis at this embryonic stage, it is going to give rise to these dermoidal tumors. So sometimes they are basically very benign sort of tumors. They need not to be treated surgically until they have their cosmetic reasons and people want to remove them or they want to surgically treat them due to that purpose. They're usually quite superficial and they're usually seen in the infancy. So it is a deep dermoid and it is usually associated with the bony defect. So all of the embryonic tumors are usually associated with a bony kind of a defect. There would be a bony defect either in the medial wall, either in the lateral wall, in the floor, or it can be in the roof of the orbital cavity, and that would give out the final picture. Again, the size, the location, and how much it is affecting the cosmetic outcome in that infant is again very important. If it is blocking the view, if it is of a larger size, then we have to give out the surgical excision in these kind of dermoidal tumors when we usually come across them. Talking about the epidermoidal conditions, this is basically one of the kinds of the primary orbital tumors, which is also related to the epidermis. Its contents, again, are containing of the epidermis, but it is the clinical presentation that is going to distinguish it from the dermoidal lesions. Over here in the epidermoidal lesions, the presentation usually would be of a cystic lesion. Usually in a lot of conditions, this cyst would also contain a fluid inside it, which can be sent for the histopathological findings for further investigations. It is composed of the epidermis, and when you're going to basically view it under a microscope, you're going to see the features of an epidermis. It is going to contain the follicles, the glands, the meibomian glands. They're almost always cystic in their origin. The treatment, usually that is encompassing the dermoidal as well as the epidermoidal lesions, is the surgical excision. But that is only carried out in cases which are causing hindrance in the vision or increased irritative purposes. There is chemosis, there is increased lacrimation, and the patient or the infant is constantly suffering from superimposed infections due to this dermoidal or this epidermoidal cystic lesions. Then only you're going to opt for the surgical excisions in these patients who are suffering from epidermoid or dermoid, because these lesions are actually not malignant. They are benign in nature, and they're not going to spread across the neighboring structures and involve the neighboring cavities as well. Then we have another kind which has its lipid content along with the epidermis, and that is regarded as the lipodermoids over here. So it is going to appear like this. It is mostly appearing in the conjunctival region. So that is the most apparent region over here. When we look at the dermoidal or when we look at the epidermoidal lesions, we usually see that they are involving the lids, or either they are involving the lateral or the medial walls of the orbital cavity over here. But when we are typically talking about the lipodermoidal cysts, they are quite small in size. They may be numerous in number, and they're usually involving the conjunctival sac. So that is the most important location. These are the whitish, yellowish nodules. They have a lipid content. Again, they are going to contain the epidermis. When you're going to examine, if on excisional biopsy, you're going to send it for the histopathological findings, you're going to observe that there is going to be the features of lipid content, and as well as there are going to be the features of hair follicles, the glandular structures. They're going to be located over here, and that is the highlight point. That is basically a lipodermoidal lesion that we're treating over here. Then mainly when we talk about the embryonic stage tumors, we come across the teratomas. Now when we say or when we use the word teratoma elsewhere even in the body, we're talking about all of the three layers, the developmental layers of the embryonic stage. Sometimes it can be a very horrific picture in an infant. It's a teratoma that is present inside the orbital cavity, and the only treatment that lies along with this teratomas condition is the surgical excision of the tumor, and you have to perform the extenturation. That is basically the evacuation of all of the structures of the orbital cavity. And after you perform this evacuation or enucleation procedure, you're going to have the prosthetic eye, and you're going to replace it in the orbital cavity that has been treated. And obviously, after the surgical excision, you're going to couple up this particular therapy with the radiotherapies, as well as you have to perform or give the coupled up chemotherapies along to this patient. So they're usually composed up of all of the layers, as I was already talking about and emphasizing on the fact that this kind of a tumor involves all of the embryonic structures, that is the ectoderm, the mesoderm, as well as the structures of the endoderm we can see or we can evaluate under a microscope. They may be solid, cystic, or a mixture of both, and mostly benign, and they're treated by the exenteration or excision. So although they are benign kind of tumors and they're not going to spread or they are not going to metastasize, but still you have to perform the enucleation procedure for these infants due to the massive effect that these teratomas are going to have, due to the compression syndromes that they're going to have, as well as there can be a very uncomfortable situation for the infant himself or herself. There can be the exposure keratitis, superimposed infections, and just to have the evaluation and just to have a better quality of life in these individuals, we have to perform these enucleation procedures to treat these patients. Now, whenever we are talking about the different structures, we have already dealt in with the developmental phases. Now we're going to move on to the vascular tumors. Now, broadly, we can classify the vascular tumors into the hemangiomas on one hand and the lymphangiomas on the other hand. So this is a broader classification. These two categories are the broader classifications towards the vascular tumors. On one hand, we have the hemangiomas that would be involving the vascular structures, primarily the arteries and the venules, and on the other hand, we'll be having the lymphangiomas, particularly involving the lymphatics. So that is the basic difference over here, that lies over here when we are talking about or when we are discussing the vascular tumors of the orbital cavity. So primarily the hemangiomas again are going to be classified as the capillary hemangiomas, or either on the other hand we have the cavernous hemangiomas. These are the subdivisions towards the hemangioma classification. We have the capillary kind and we have the cavernous kind. Capillaries would be the slight vasculature or the minute vasculature that is located inside the orbital cavity. And on the other hand, the cavernous sinuses, if they're involved and there is an AV fistula that is related to it, we're going to relate it to the cavernous hemangiomas. So what is the presentation of these capillary hemangiomas? It usually presents during the first month of life, and usually the parent would come up along with the complaints that upon crying and upon straining, there is this mass that can be felt inside the orbital cavities, or that is basically a pulsatile, or that is an infantile mass that is protruded on straining, or that is protruded on the crying of the baby. So this would be the most common presentation, and you can just quickly have this differential diagnosis in your mind that this infant is suffering or may be suffering from a capillary hemangioma. So this is very important that you focus on these facts and you quickly have this thing in your mind that this is how you're going to make the differential diagnosis in this particular patient. It is commonly seen at birth or during the first month of life, and these are the important characteristics involving the capillary hemangiomas: increases on straining, on crying, on regression. So this is very important. And then the periocular swelling. So it is going to be presented as a periocular swelling rather than a swelling that is located inside the orbit or that is involving the conjunctiva or the cornea or the other structures of the orbit itself. Rather, it is going to be a periorbital swelling in the anterior part of the orbit. Then we have the, when we talk about the capillary hemangiomas, one should know that what would be the treatment or how would you encompass such patients. The prescriptions would usually consist of the systemic beta blockers. They have their own mechanism of action. We can also prescribe this patient with the low dose superficial radiations along with that. Cryotherapies, if the patient is unresponsive to any of the above treatments, we can also try on this kind of the cryotherapies. And if the patient is unresponsive to all of these treatments, then we would be performing these surgical excisions in these individuals. And we can also couple up this particular therapy with the systemic or with the intralesional steroids in these individuals. So this would be the particular kind of the treatment modalities over here. When we are treating these patients and they are being unresponsive, we should know and we should keep in mind that these beta blockers or steroidal therapies, either systemic or we can also try them on as a topical therapy. Now, as well as the cavernous hemangiomas, on the other hand, we've already mentioned the fact that if it is the cavernous sinuses that are involved, we have a certain kind of communication between the orbital cavity and the cavernous sinuses. The infections as well as the tumorous conditions can spread quite easily from the orbital cavity towards the cavernous sinuses. The occurrences over here would be a common benign orbital tumor in the retrobulbar massive cone. The progression would be quite slow. It is usually unilateral. Axial proptosis is seen in these individuals because this cavernous sinuses and any tumorous condition that is arising in the cavernous sinus is going to be located or situated in the apical cone. Again, they may compress the optic nerve in these individuals, and as well as this particular, once you have diagnosed this patient to be suffering from a sort of a cavernous sinus hemangioma, the treatment obviously would start off with giving the systemic steroids or with the coupling it up with the beta blockers as well. But if all of these treatments are not remitted or they are unresponsive to, then you're going to perform the surgical excision via the lateral orbitotomy approach. So this would be the particular approach that you're going to take. Once you have to keep in mind it's going to be a surgical procedure, the approach is going to be laterally because that is the most easiest way to reach the apical cone of the orbital cavity that has to be treated. So this is the complete review or the summarization of the condition, which is known as the cavernous hemangiomas over here. The vascular tumors have a broader classification of lymphangiomas. The lymphatics are lying inside the orbital cavity and they may be affected by any kind of a tumorous condition. So if that is the case over here, then the progression is again very important. Lymphangiomas usually behave in a very slow kind of a progressive manner. Proptosis is associated with it because the mass is located at the retroorbital space and is going to push the contents in the forward direction, and that is going to give off the effect of proptosis in these individuals. The enlargements over here are quite conspicuous due to the spontaneous bleed within the vascular spaces over here. Then the lymphangiomas have their particular presentation, that is the cyst formation that is seen. Usually when there is a rupture of the lymphangiomas, they give a chocolate cyst appearance which may regress after a few days. So that is the mainstay of the presentative features or the clinical signs and symptomatologies when we have a case of lymphangiomas occurring in the orbital cavity. Having done the discussion of the vascular tumors, we have the different varieties of the embryonic tumors. On the other hand, we have a major classification of the mesenchymal tumors. The mesenchymal tumors would consist of the rhabdomyosarcomas over here. So that is the major classification over here, that they may be basically giving out a presentation of a rhabdomyosarcoma like this. It's basically the striated muscles that are being subjected to the tumorous conditions. Usually there would be this particular massive swelling, usually located in the floor of the orbit. The child is usually suffering from a defective floor or a lateral wall or a medial wall or a roof of the orbital cavity, and that would basically encompass or locate the rhabdomyosarcoma over there. So the types that are encompassing this kind of a condition is the embryonal sarcoma. We have the alveolar sarcoma on one hand, and we have the pleomorphic sarcoma, depending upon the histological picture and the kind of staining, whether it is a basophilic staining or either it is an eosinophilic staining. That would basically classify it to be one of the kinds of the embryonal kind, or either it is an alveolar kind. Or on the other hand, we have the pleomorphic variety that can behave quite well in a malignant kind of a state. Now, whenever we have the features or we are discussing or looking at a patient of rhabdomyosarcoma, it commonly involves the superior-nasal quadrant. The patient would also complain of proptosis. That is again due to the fact that there would be a retrobulbar mass which is going to have a push on the structures of the orbital cavity in the forward direction and giving out the proptotic appearance towards the eye. Now, when you have these features, you basically have located the mass and you know that the patient is suffering from proptosis. You have the differential diagnosis in your mind. Maybe it's some sort of an inflammatory reaction or an autoimmune disorder that may be giving the picture of a proptosis in the patient. But you're going to confirm this diagnosis of rhabdomyosarcoma by performing the biopsy. That is the excisional biopsy being done over here. Now, the CT scans and MRIs are also done for these patients. The X-rays are showing the bone destruction in these individuals or in this regard. Now, this bone destruction again is very important over here because the radiological examination is going to reveal a lot of facts over here. The treatments would consist of excision biopsy, and obviously that is also diagnostic as well as that is a part of a treatment that is carried out for these patients, because you have to remove the mass. Either it is an inflammatory kind of a mass, or whether you are suspecting it to be a neoplasm or a rhabdomyosarcoma, you're still going to perform the excisional biopsy, and then you're going to perform the chemotherapy for these patients if the patient is found to be having the rhabdomyosarcoma. Then also you're going to perform it or couple it up with the radiation therapy, and then finally you're going to perform the exenteration techniques for these individuals as well. Obviously, you're going to give out the chemotherapy, that is the vincristine, 2 milligrams on day 1, and that is followed on by giving this vincristine 2 milligrams on day 5 as well. Then you're going to couple it up with actinomycin D, that is 0.015 milligrams per kilogram IV per day for 5 days in these individuals. You're going to couple up this with cyclophosphamide, which is 10 milligrams per kilogram once a day for 3 days in these individuals. This is the complete chemotherapy given to these patients, and obviously it's just not an isolated chemotherapy that we give to these patients. It is coupled up with the surgery as well as with the radiotherapy in these individuals. Having done with the muscular involvement, muscles, nerves, all of these structures can be involved in the neoplastic conditions. When we talk about the neural tumors, there is a syndrome that we usually come across, that is the von Recklinghausen's syndrome. It's one of its kind, in which basically the patient has neuronal tumors, so it can also involve the orbital cavity. Now we can have another variant, which is basically the optic nerve gliomas. The patient is again going to present with a mass in the orbital cavity. It can be a retroorbital mass, proptosis, lacrimation, exposure syndrome, compression syndromes. All of the features of the location of a mass are going to be seen in these individuals, and Only after a histological biopsy or a histological confirmation, you're going to diagnose the person to be suffering from an optic nerve glioma in these individuals. The features over here would consist of the gradual visual loss in these individuals, and then the patient would be having a painless unilateral axial proptosis due to the pressure effects of a mass which was located in the apical portions. Then the patient might be suffering from the papilledema or the venous engorgement, which is only visible when you perform the fundoscopy in these individuals. There is going to be a pallor, there is going to be a retinal atrophy that is observed in these patients. The fundus examination may show the optic atrophy. So both of these signs, that is the papilledema, the optic atrophy, they're going to be confirmed when you perform the fundoscopy after the dilatation that is given, that is the pupillary dilatation it is given, and you perform the fundoscopy in these individuals. The diagnosis and the treatment over here would consist of x-rays, of course. Then you're going to perform the CT scans, the radiological imaging, the ultrasonographies are done. The surgical excision of the tumors by the lateral orbitotomy is also done along with that. The radiotherapy given in the inoperable cases over here. So over here, you can just have a view that you can perform the surgical excisions, you can perform the radiotherapies for these individuals along with that. The meningiomas can be one of the variants of the neural tumors over here. We have the primary intraorbital meningiomas over here. The features of the primary intraorbital meningiomas would consist of early visual loss, unilateral proptosis. The diagnosis would only be made when you perform the radiological imaging. For example, the CT scans are quite diagnostic over here. And the treatment would consist of the observation and the surgical excision. So obviously, as we have already learned through this complete discussion, that the surgical excision is the mainstay when we have diagnosed a person to be suffering from any sort of tumor. And then you give off the chemotherapies and the radiotherapies depending upon the cases. The secondary orbital meningiomas have the features of greater proptosis and lesser visual impairment. The swelling is going to be a boggy eyelid swelling, and ipsilateral swelling in the temporal region is also noted down in these patients. The diagnosis, for the diagnosis, obviously, CT scanning, radiological imaging, MRIs are done for the assessments. Even after the treatments, these CT scans, and you follow up the patient with these radiological imaging techniques, performing CT scans or performing MRIs, are even prescribed after there is a complete surgical excision and you have treated the patient completely. There is going to be a subtotal resection, and you can also perform the post-operative radiotherapies for these patients as well. Now, classification of the lymphoproliferative tumors is also very important. We have the lymphoproliferative tumors, and we subclassify these tumors as the benign reactive lymphoid hyperplasias, which are quite painless, and there are the features of proptosis, and there is a feature of a salmon patch that is present over there. They're usually treated via the systemic steroids, and this therapy is usually coupled up with the local radiotherapy along with it. There is an atypical lymphoid hyperplasia along with it that may involve the other systemic organs. Usually, it doesn't respond to the steroidal therapy in these individuals. So basically, you have these two major variants over here, which is responsive to the steroidal therapy. And on the other hand, we have a group of this lymphoid hyperplasia, which is not responsive to this steroidal treatment. On the other hand, we have the mild lymphomas. 40 to 70% of all the orbital lymphomas, they are usually unilateral in their nature. There's a gradual proptosis that is seen, palpable, or a rubbery mass is usually seen in these individuals. And mostly they are treated via the radiotherapy, which is coupled upon the chemotherapy. You may perform the surgical excision as well, and sometimes all of these therapies are coupled along in cases of unresponsiveness that is noted down in the patients. The types would include CLL lymphomas, and that is basically a low-grade lesion of lymphocytes. We have the FC lymphomas, that is the low-grade lesion with the follicular centers. Again, histological features are very important. When you see these rounded follicular structures, that would basically regarded to be an FC lymphomas. Or on the other hand, if there is a low-grade differentiation, that would be regarded as the CLL lymphomas in these individuals. On the other hand, we have the high-grade lymphomas that are particularly also known as the Burkitt's and the large cell lymphomas. They would be seen these large cells that are usually basophilic in nature. On histopathological findings under a microscope, you can observe these basophilic structures and appreciate the presence of the Burkitt's lymphoma or the large cell lymphomas. We have a Langerhans cell histiocytosis. It's again one of the disease groups. That is the Hand-Schaller-Christian disease. It's known as, or it's another name for this kind of a syndrome over here. There is a chronic disseminated form of histiocytosis that is seen in these patients. We have Letter-Sive disease, which is a systemic form of histiocytosis with soft tissue involvement. And another group of diseases, which is usually unilateral or multifocal eosinophilic granulomas in these individuals. And they can be solitary in nature, they can be multiple in their number. And these granulomas are usually involving the bones. So again, when you send the excisional biopsy for the histopathological findings, only then you can come up to a definitive diagnosis in a patient of orbital tumors. We have once we have discussed the primary orbital tumors, we have another group of, or a broader classification, which is known as the secondary orbital tumors over here. We have the tumors of the eyeball, which basically involves the malignant melanomas. We have the retinoblastomas involving the retina. And on the other hand, we have the tumors of the nose, the paranasal sinuses, the nasal cavity itself, which would include obviously the bone tumors, which can be benign or which can be malignant in their origin, ranging from the osteomas, the sarcomas that are malignant in their origin, and then we have carcinomas which can metastasize to the distant organs or towards the distant regions of the body. Talking about the secondary orbital tumors, we know that the tumors of the eyelids that can be involving the lower or the upper eyelid, they have their own pressure symptoms. They are irritative in their purposes. They can block the vision or hinder the vision in the individual. The patient may be suffering from a squamous as well as a basal cell carcinoma. The tumors of the nasopharynx it can be the carcinomas as well as they can give the presentation of proptosis in the individuals. And the cranial nerves are also involved due to the fact that we have the third, fourth, and the sixth cranial nerve passing through this orbital cavity. The tumors of the cranial cavity itself can be the gliomas as well as the meningiomas depending upon the location of the tumors. In children, the tumors can metastasize. It can be a neuroblastoma. It can be a nephroblastoma, which is basically metastasizing from the kidneys. It can be an Ewing's sarcoma, as well as a leukemia infiltration, blood disorders, the blood dyscrasias infiltrating in the orbital cavity. as well as it can be the testicular, embryonal, and the ovarian sarcomas, which can also metastasize towards the orbital cavity. So sometimes this distant metastasis is present, and tumors do invade the orbital cavity from distant areas, and they're involving the orbital cavity and giving out the features of proptosis, cellular infiltration. It's depending upon the investigation. You would carry out the bone scans and you would carry out the radiological imaging of the rest of the body, and that would basically highlight the fact whether the tumor has metastasized from a distant area or it is a primary orbital tumor. Metastatic orbital tumors can also occur in the adults as well as in the younger individuals or in the infants. So the carcinomas from the lung, breast, and prostate can also metastasize to the orbital cavity, as well as the malignant melanomas from the skin. They may also metastasize to the orbital cavity. So all of these presentations can be in an adult individual as well as in an infancy stage. Over here, when we compare these tumorous conditions in children and also in adults, we see that the primary benign tumors, they usually present as a dermoidal cyst in the children, as well as in the adults, they usually present as the cavernous haemangiomas. So these are the most common presentations of the orbital tumors over here. Then we have the primary malignant tumors. In children, they usually suffer from the rhabdomyosarcomas, and in adults, they suffer from the lymphomas. The secondary tumors most commonly located most commonly diagnosed in the children are the retinoblastomas, while in adults, they're usually the squamous cell carcinomas. The metastatic tumors in children are usually the neuroblastomas, and in adults, they're usually the carcinomas of the lung and the breast. So over here in this lecture, we just summarize the different tumorous conditions that can arise in the orbital cavity. Depending upon whether it is a primary orbital tumor or a secondary orbital tumor, or it is a metastatic tumor, we are going to modulate a treatment guideline for these individuals. And one should be well versed with the signs and symptomatologies as well as the treatment modalities available out there to treat these patients. So that is the end of this lecture. Thank you for watching sqadia.com.